Good afternoon, and welcome to our webinar on how technology can improve patient experience and performance in healthcare. Innovations in healthcare go hand in hand, and we've seen significant advances in how we treat sicknesses and diseases. Before the 20th century, life expectancy was below 50 and started to increase to about 80 now today. And the rise is due to a large part, and obviously our better understanding of our bodies and our health, but technology has played a major role in treating illnesses, diseases, and conditions. And today we also see positive impact through better information sharing, data monitoring and collection, and easier access to our health information. And I think we're still at the very early stages of leveraging technology to improve patient outcomes. Today I'm joined by Dr. Inga Lennes from Mass General Hospital. As the SVP of Performance Improvement and Service Excellence, Dr. Lennes is spearheading MGH's strategy to increase patient satisfaction and maximize outcomes. Dr. Lennes is well positioned to be leading this charge. She's a board-certified thoracic oncologist, graduating from the University of Massachusetts Medical School. She has her master's in public health from Harvard, and just for good measure, also has her MBA from MIT Sloan. Inga, can you tell us a little bit about yourself and what you do at MGH?
Hi, everyone. Thanks for joining us today for this webinar. I'm really excited to be here. As you said, Bill, first and foremost, I'm a lung cancer doctor. That's what I continue to practice at MGH. But increasingly over the last 10 years, I've also taken on more administrative roles. I was the Director of Quality and Safety for our cancer center for almost a decade. And then a few years ago, I became the Senior Vice President for Improvement and Service Excellence for MGH and the physicians organization there. In that role, I look after mainly our ambulatory operations and also how we measure and execute on improving the patient experience in every arena where we deliver healthcare.
Okay, and you have, in fact, you sent me a slide on the MGH, what you call the MGH New Patient First Encounter. Can you tell us about this?
Sure. Like I said, we've been spending a lot of time really focusing on our operations and experience in our ambulatory areas. So we also do pay a lot of attention to the inpatient experience as well, but 97% of the touches to our patients actually happen in the ambulatory outpatient units. And so this slide, what it does is sort of outline the journey that a patient might take. And it's actually very complex to go from not having an appointment to having a new appointment in our clinics. And it involves many of these stops along the way. It's a complex process, and there are many different interdependencies. And in a large healthcare organization, different places may play different roles. So there may be different management structures around all of these different areas. So patients are searching for appointments in a variety of ways. There's multiple different channels to find appointments. We see people increasingly searching on the internet, but they can also be referred by providers who are in network, referred by providers who are out of network. There's also the scheduling process. Increasingly, we're seeing better technology and user interfaces for direct scheduling, or the ability for a patient to schedule their own appointments online. But we also have sort of the old-fashioned way through phone calls and talking to our scheduling assistants. Part of scheduling involves checking for an insurance eligibility and then preparing for the appointment. Many times for some of our complex appointments, we need patients to be giving us some of the medical information that they have that might be housed in different places. So it's gathering medical records, often by secure faxing technology or by other ways of interacting with different healthcare organizations. It might be actually retrieving information directly from patients in the form of questionnaires or accessing our electronic health record portal. There's the process that happens when a patient arrives, which we actually counted up all the steps that a front desk worker goes through when a patient arrives, and depending on the patient, it can be as many as 32 different steps that have to be executed at the point of patient arrival. there's the actual care that happens in a clinic, and then there's all of the follow-ups. So everything that happens after the appointment, making the next follow-up appointment, any testing that has to happen, communication with patients. So these are, there's many different things that go into executing well on a new patient first encounter. And we really view our work to enhance the coordination across all of these cross-cutting functions that involve both information systems, but also partnerships with practices themselves, and then different parts of the administrative team to really improve that access experience for patients, but also our providers and staff. MGH is a large employer in the region, and so we want to make sure that the people who are working at our front desk and in our clinics enjoy the process of the work that they do and find it fulfilling. So all of these things are part of our work together.
Wow, that's quite a that's quite a process. And MGH, I mean, how many patients or how many people kind of go through the doors at MGH on a daily basis?
Sure. So in our ambulatory units, we see almost between 12 and 13,000 patients a day. So it's over 4 million outpatient visits a year that happen, not just in MGH, but in our family. We have clinic family members that are not just in downtown Boston, but in other places like Waltham and Danvers and other outpatient places. So, but all told in the MGH family, there's about 12,000 patient visits in the ambulatory side a day. On the inpatient side, we have about 1,000 beds, give or take a few. So like I said in my introductory report remarks, that we're often very well known for our quaternary care and the really intense and technical inpatient care that we deliver, and the academic research and all of those things that are going on in the hospital walls. But the majority of patient touches, the times that patients experience care at MGH, the majority of that, like I said, about 97% of it is happening in the clinic.
Wow. So even a small percentage improvement can, with that many people and that many patients a day, can go a long way.
Right. Often the intensity, obviously, of the care is much higher as an inpatient, and that's something that leaves an indelible mark. Is when you're an inpatient, there's usually something that's serious that's going on. But what we find is that we have a lot more opportunity to improve the experience on the outpatient side, just because of the volume of experiences. So you may go see someone, and you may have one hospitalization every so many years, but you'll see several different providers, a primary care provider and a few specialists several times a year. So the average patient might be seen in our outpatient clinics maybe 12 or 20 times, and they may be accessing services like x-rays or lab testing. So there's just a lot more frequency of interactions with patients who are coming in for ambulatory services.
I see. Okay. Well, so hospitals at the highest level, obviously the mission is to see patients, to care for patients, and to make sure that patients are satisfied and they have good outcomes. But beyond the obvious of making sure that you're helping cure diseases and make people who are sick healthier, how does MGH think about how you care about patients, and what are kind of the key aspects that affect that patient satisfaction and outcomes?
Well, I would say, first of all, we try to be as scientific about it as possible. So we do measure it. We use several different tools across the organization, but the most common ones are something called HCAHPS for inpatient experience, which is the CMS required tool that we use to measure inpatient experience. And then we also use CGCAHPS, which is the outpatient or ambulatory tool. And then we have some different tools that we use created by companies like Press Ganey and different other parts of the organization where the CGCAHPS tool isn't appropriate. So we first try and approach it somewhat methodically by measuring it. And then we also really try to involve patients in understanding the patient experience. So we have 12 different patient and family advisory committees across MGH where we involve patients and their families directly to tell us about the experience that they've had accessing our care, and that goes a long way to help direct the improvement initiatives across the organization. So that's, I think, the first way. And some of you asked me about what kinds of things do we measure, and I think one of the most powerful questions that we ask patients is whether or not they would recommend us. We know from promoter scores and entrepreneurial activities and other things that when someone says that they're willing to recommend a service or a provider, that it really is saying a lot. And so that's one of the most important things that we measure.
Right, it's a pretty high indicator of just overall satisfaction.
That's right.
Yeah, and so you're involved. Obviously, the clinicians and people who are caring for patients care about the patient overall experience. But who are some of the key stakeholders, kind of at an administrative level, that are kind of looking at this problem?
Well, every single area across the organization has an administrative team that's looking after the operations, and so those are the stakeholders that are very invested in our patient experience. We hold ourselves to a very high level, and we actually internally incentivize a good patient experience. There is something that we call the internal performance framework, where across actually all of Partners Healthcare, that includes MGH, we set goals for ourselves for different patient experience goals based on the scores that we receive, and then we internally sort of withhold or penalize or reward ourselves based on meeting those goals. And so that's how important it is to us that the patient experience is really held up as something that's very, very important. And so those incentives are really trickle through the entire organization in terms of incentives for our leaders, but also for our divisions and how we structure our budget framework. So it's something that really has tentacles, I would say, throughout all of different layers of the organization.
Right. And so, a lot of this is obviously, as we see kind of the surge in efforts to modernize healthcare, MGH is one of those hospitals you think of as, the premier hospital in the world. How does, I guess I'd be interested in understanding how MGH approaches the, use of technology to, try to positively impact, patient satisfaction. So do you have any examples where MGH has been really successful in using technology to improve patient care?
Well, beyond, as you mentioned, there's so much technology that's involved in just actually delivering healthcare, from robots in the operating rooms to, different technology that we use to deliver radiation. And so the technology is in healthcare delivery, I think, more and more than we've ever seen it before. But then there's the type of technology that is invisible to patients behind the scenes, that helps with communication and knitting together some of the operational processes that go on. And some of the things that I'm most excited about for patients are really improving communication. So we're very excited about new texting technologies to be able to leverage the ability to text patients more concisely with appointment reminders and have them execute changes to their schedule through smartphones, things like that. That technology improvement in the portal where patients access our EHR online, I think is another area that I'm excited about. I think healthcare is a bit behind. If you think of all the things that you can do on your phone with an airline, and then you compare that to where we are in healthcare,
Right.
I think we're getting there, but there's some more places to go. But many of the advances that I see, I don't even know that patients would actually know that they're happening. They just have more of what I would call a frictionless experience. So, for example, I think we may have seen years ago where faxes were lost, that nobody, paper didn't work, or there's something. Records were very hard to translate back and forth from places. What we're seeing more and more is that just happens seamlessly and behind the scenes, and the patients may not know that it could have been a problem before, but it just happens in a seamless and frictionless way now.
Right. And you said kind of like, healthcare is a little bit behind things like the airlines and other industries. Why is that?
Well, I don't know. I think it's complex. So I certainly, if I knew the answer, I think. There's probably several reasons. One is that there are issues at stake in terms of HIPAA and compliance. So, there's
Right.
Information that we have to be very careful about protecting, and that's very important. So I think in some ways we haven't seen as much fast-moving changes where this is concerned, because we're trying to balance privacy and some of those concerns, which is very important. I think also until the last 10 years, we haven't seen a lot of incentives for interoperability and for the ability to communicate freely, and we're still challenged by that. We have more consolidation of EHRs across the country and better interoperability and communication than we've seen before, but it could always be improved. And then I also think too that the entire profession, if you go and see a doctor, the order of operations hasn't really changed that much in the last 30 years. You go to the front desk, you check in, you might see a nurse, you have your labs drawn, you walk into a room, you have a 10-minute, 15-minute, 20-minute discussion, you order some tests. I think, what we're really going to see in the next few years is that model being turned on its head, with the addition of more telehealth for people being seen through computerized visits, for more ability to bill for those different types of creative healthcare, where we don't have to use each visit as a marker for healthcare payment. I think that those types of changes in the payment structure and the availability of new technologies that really promote telehealth are going to change how we deliver healthcare, and we'll see that change.
Yeah, I think it's really important that we don't just think, okay, it's always been done this way and we need to continue. But I also understand what you're saying, where there's additional risk, especially around patient information and the confidentiality aspect. So, those can certainly be at odds. But when you do look at new technology, and so say we're trying to bring in a new piece of technology into a hospital like MGH, what do you have? I mean, is there kind of the criteria that you use, common criteria to assess the technology, or even decide whether or not you want to try it out?
Well, I think one of the first things is I always ask this question myself, and I counsel my team to ask this question of anyone who's coming to speak to us about a new technology, is what's the problem that the technology is solving or attempting to solve, and do we have that problem? I think that there's a lot of things that are very interesting out there in terms of new technologies, but I think being really clear about what is the issue that we're trying to solve, and then also what other balancing measures or what other things could this introduce that are new that we'll have to be aware of as we implement it. And then I think one of the biggest challenges for us also is what the support model is going forward. So there's a lot of really interesting things out there. So one of the biggest challenges I have is making sure that A, it fixes the problem that we have prioritized that we really want to fix, and then B, what is, how are we going to support that technology going forward in a very large organization, and then scaling it. It might be great for one very small pocket of the organization and making the decision that that's the place where this should live because it really is important there, versus a larger solution that we really need to scale across the entire organization. So that's those are some of the three things that I think about whenever I'm looking at new technologies. But most importantly, does it actually solve a problem that we would like to solve?
Right. Right. No, that's the most important question. I have seen instances where, you put a product into healthcare and it's, a single department that's using it. It doesn't seem to spread, right? I mean, this is something that, potentially lots of different departments can use. Why do you think that happens? Like, why is there just like, okay, other areas don't go, oh, that we could leverage that as well. We already have it in place here. Is there anything kind of stopping
That's
that,
really
or is
good.
it just,
Yeah, it's a great question, and it's one that we've spent a lot of time doing some self-reflection about. I personally think it's because of how healthcare has grown up over the last 50 years. So, and I'll speak just basically about MGH, but there's, the inpatient beds and units really solidified around the physical structure of the hospital. There's walls, there are head walls for beds. There's a shared infrastructure there. Ambulatory or clinics are a little different. There's hospital-based clinics, and then there's clinics outside of the hospital walls in different buildings and even across a region. And many of those ambulatory clinics were run by, private groups that were affiliated with hospitals. And what I mean to say by this is that in how those structures have grown up, in some places there's not necessarily the infrastructure to spread an innovation like something that you might want to spread across an ambulatory unit, like because they all have their own separate organizational and administrative structures. I see that changing because just because of what you said, there has to be some organizing body, and we do see great improvements and really, I call them local superstars, local innovations, where we've seen one group that has really taken to a certain technology or has leveraged something really well. But one of our challenges is to make sure that we can then spread that across the organization really cohesively. And up until fairly recently, there hasn't been always the management structures to be able to spread something like that.
so Inga, that's really, I mean, a good point. The physical barriers often result in just, that lack of communication. I think that's where I think technology is also one of those areas that can help bridge those, those kind of siloed departments. So, where do you,
I will, go ahead.
Go ahead.
Sorry. I see that too in the technology groups that come to talk to us, is that they're often spending time pitching each, and they know this about our ambulatory structure, so they pitch each and every different division separately because they know that there's not always that bridging infrastructure that goes between all of the different units. And so we hope to streamline that a bit as we introduce new technologies into this, the ambulatory side of our operations, so that entrepreneurs and companies don't have to work so hard to get to all of us, which is a challenge. I think that's what I hear from my partners who are
Right.
bringing these new technologies to us.
That's also, I think, a complaint from the vendors, who are, how do I get my technology into this? So speaking of that, like, how do you actually, I mean, other than people who go and try to call you and say, hey, Dr. Lennes, we have this great, gizmo for you. How do you go out and find technology that you're looking to, for problems you're looking to solve?
A variety of ways. Like you said, we do just get calls from many different people with great new companies, ideas, or even established companies. We also participate at MGH in the Pulse and the Mass Pulse Challenge, which is collaboration with state government and a hackathon for, there's also Hacking Health and some other different groups that MGH has been a volunteer for, a supporter in those programs, supporting entrepreneurs as they try and unravel different vexing problems in healthcare. So we try to be a good partner to development of new technologies, and there's been some really fruitful collaborations. We also have a few in-house innovation centers that are looking to partner with, they have their own internal ideas, but also very willing to partner with different innovators and entrepreneurs in the ecosystem around healthcare for co-development and other types of arrangements. So MGH has a variety of different, from very high touch and embedded innovation to lighter touch and being sort of a pilot site for different groups. But we get contacted in a variety of ways.
Mm, okay. And once the technology, so you've gone through the process of evaluating it, and you actually bring it in, do you see some cultural resistance to adopting this new technology at times?
Oh, definitely. Like I said, there's some things can work really well for one unit, but not as well for others. There's some things that that have to be optimized. You know, I think that's another sort of central struggle is customization versus standardization, and that challenge is always that balance, getting that balance right to have something optimally customized, but not so customized to the point that it doesn't work for anybody else. Is a challenge that we're always facing. People like their own workflows with their very specific ways of doing things, and so that's something that we're always addressing, I would say, in operations across a very large organization.
Yeah, and part of that is kind of this ease of use too, right? So beyond the fact that people don't like change, if you do implement or introduce something new, I think it has to be really easy to use, right? I mean, doctors are no different than anyone else in that respect.
Oh, definitely. I think that's one of some of the hard things is some of the technology changes haven't always brought ease of use. You know, there's several different articles that have cited the increase in burnout in providers, and while we have some technology that has improved many different areas of healthcare, it's come at a price, and that's in the price of clicks, and different types of work that has to be done now. And so we're always trying to balance that, the efficiency that we get from some of these different things with the burden that comes with it. But the holy grail is something that improves efficiency and adds no burden or even relieves burden. And so that, whenever we find those pockets of technology out there, we are really excited about it because we've accepted some of the increased work to be able to realize the efficiency that comes with some of the new technology. But I think that the next decade is going to be about finding ways to do this without adding or even taking away burden.
Mm-hmm. In fact, I think physician burnout was a pretty hot topic at the last HIMSS conference, and I think part of that is just the overwhelming amount of work and paperwork and processes that doctors have to go through now and patients have to go through, and the fact that people are spending less time with the doctors face to face.
That's absolutely true.
Yeah, and based on that, I mean, one of the things that we're definitely in this, I think, just approaching this golden age of information and data collection. We can analyze it, we can use it, we can apply it to patient care. Obviously, EHR usage has skyrocketed in the last decade, but because of meaningful use. So, what about MGH's any initiatives around from MGH around increasing information management and sharing?
There's I was chatting, I think it was with you actually, in preparing for this about the there's a really interesting article that just came out from in Fortune and Kaiser. I think it's called "Death by 1,000 Clicks" or something like that. And I think that the promise of interoperability and portability of our EHRs is something that we still haven't realized. And so what's really important is to be able to smooth those edges and to make the experience very frictionless. So some of the examples of that are things like secure faxing. So we still have to fax documents. It still has to be secure. And also file image transfer. So oftentimes we have to receive images from other different organizations and even have an ability to integrate them into our electronic health record, or not, depending on if the patient is coming to see us or not. But they have to be visible to the providers that might be making a decision or helping to counsel on whether or not it would be the right thing to do to see the patient. So, and those are some of the technologies where we've seen that it's been very useful to smooth the edges of the places where we see communication with other organizations or communication with patients hasn't been optimized yet by our EHR technology. We've also seen great uses for companies that we work with that help to improve communication, like I said before, with texting patients, which isn't always something that is that we can get just directly with our EHR itself. So those additional technologies that help to make those processes of the EHR work much better are incredibly important.
Right. So, and I totally agree on all of that. One thing, I mean, I think some of the promise of EHRs is just kind of speeding the or increasing the speed in which you can share that information. So, how does speed actually impact you, right? Because I mean, okay, I'm talking
Yeah.
as a patient, but I'll sit in the doctor's office and I'll be waiting and waiting and waiting. Something, test is done. I'm just waiting there. What am I waiting for? Is it for the test to be done? Is that information to come back? But so
Yeah.
what's the problem? And then
Um,
also, what would be the benefit of having that faster?
well, I think we know that patients that get appointments sooner are more likely to keep them, and in competitive healthcare environments, our ability to place you with the right provider very quickly is really important for our business. There's lots of other choices for great healthcare, especially in Boston. So, but I think also we need to place you with the right provider. So that means that there might be some aspect of your medical record, a patient's medical record, that's necessary to view first. To make sure that that specialist in cardiology or that specialist in cancer is the right person for you to see, and also to make that visit very fruitful. We could just make appointments for patients without having any of the background information, but that's not as fruitful always in discussion. So we have to balance that. We want to get patients in very quickly, because the sooner we know that every single day that goes between the time that a patient calls or contacts us for booking and when we actually set them up with appointment, that you can see plotted out by time very quickly that the longer those days stretch out, the bigger the fall off in terms of patients who don't show up for their appointments or they go someplace else for care. So getting patients in fast is really important. But it's also very important for our providers who find it more satisfying to see patients, when they know that they're the right patient for them. Many of our subspecialists see very specialized diagnoses. So we have to get that information in quickly. I think also for the patient side, I was remarking to someone the other day, I had a screening test myself. I had a mammogram a couple of weeks ago as part of my regular care. And I have to say that I was delighted that I got an EHR alert just a few hours after I had my mammogram that told me that to check my EHR portal, and the results were up telling me that everything was fine. And I really thought to myself, gosh, that makes a difference. That makes an actual difference in the quality of my life, because if I had a test on Friday and I might need to wait till Monday or Tuesday or Wednesday to get that report back, I'll be fine, but I'll worry about that. And
Right.
I think
psychologically,
to me, yeah, it made a big difference. And I enjoyed my weekend, and I didn't think about it again. And I thought to myself, that's really important. These everyday things like that are very important to patients. So, and we all are patients ourselves too. I might be a physician, but I'm also a patient too.
Right. What about security and privacy? You touched on some of the HIPAA requirements, but how does that impact how you communicate with patients and peers and other facilities? Because that has to be protected.
Yes, it really is top of mind with every form of communication. We work really closely with our health information management colleagues, which We have several people who are experts, lawyers and others across not only MGH, but we work with in the context of Partners Healthcare. I think that is our foremost concern. I think, we balance that with high quality and with efficiency and expediency, but we can't sacrifice any form of confidentiality. So it's always the top of mind. I think, though, we're always trying to find a way to balance it, though, so that we can make sure we maintain the highest standards, but that we're able to find ways to be more efficient and more communicative. So, and I'll give you an example of one of those ways that we think about right now is in how we text patients. We have patients' cell phone numbers. We want to make sure that we're not texting them and having them get charged by their cellular service. We have to ask for permission to be able to send those texts. And we're balancing doing that with being very efficient and using that more and more, because we want, in a modern world, we want to communicate with patients in a modern way. So, but we don't want to ever sacrifice anything and send someone a text which might include, medical information that they never wanted to get or didn't agree to. So we have to balance all of those issues very carefully. But I would say that the society is pushing us to move faster where this is concerned, because I think we are learning more and more from the generations that are coming next. And, we've done many different focus groups with patients who are younger. And, the way that they interact with technology to do all sorts of commerce and communication is very different than the generations before them. And they're going to push us to move faster in this front.
Right. And based on some of that, your discussions with them, how do you think, it's going to change? Healthcare will change from a technology standpoint over the next, 5-10 years. Any predictions? I know.
Yeah. I do think that more and more healthcare is going to be delivered through our computers. I think we are starting to realize that because of what's gone on in the revolution with EHRs, is that many of our providers, physicians and nurse practitioners, PAs, et cetera, are interacting with patients in visits, but almost for the entire visit they're looking at the computer because they need to be able to do all the clicks and fulfill the EHR. It begs the question, if you're really looking at the computer for the whole time, like did the patient actually need to come in? And we see from people who are ahead of us where this is concerned, Kaiser is one example, that lots of routine care can be delivered via telecommunications options. And so I'd like to see a lot of what we call well-person care be transitioned from in-person care to electronic. I also think that from a patient experience standpoint, if you think about what's needed to actually go to a visit in Boston, you have to fight Boston traffic, you have to pay for parking, those types of things. Patients aren't going to stand for that anymore. Like when they're not actually ill, when they're coming in for a checkup or there's something that is what we would call routine care. Now, illness-based care or, obviously critical care or complex care, those are things that we absolutely do need to do in person, and the art of delivering healthcare is not going to change. We have to lay eyes and do exams on patients and things like that. But I do think there's an awful lot of healthcare that is communication-based and can be done without having someone in person in front of you. And there's a lot of that you can actually, we have a telestroke program where we actually have doctors that are evaluating patients who've had stroke via a computer, and helping out other doctors who are caring for them. So there's even some exam that can be done, via a telepresence. So I think that's going to be one of the biggest things that changes over the next few years.
And one thing you forgot to mention is the fact that not going into the hospital will save you from potentially, contracting an infection or, with all the sick people around, it's probably, fairly easy to just accidentally, get sicker.
So definitely. We want to keep people in their most healthy environments whenever we can, and that's really important for them and for us.
Okay. My last question, Inga, and is this: if you had a magic wand that could instantly fix different areas of healthcare, what would you do with that?
I really, one of the biggest pain points for me and frustrations is that I see that many of the building blocks for a fantastic patient experience exist in the healthcare systems that we have. But like I said, almost like a smoothing function or like glue between these different functions, we need things that will take away the rough edges so that we're always talking about a frictionless experience. And that article that I referenced that was just published really details this very well, in that, you know, the some of the coordinating functions that we see that could be much better with communication with patients, with aggregating records, with coordinating very complex care, maybe with many different appointments, for coordinating insurance eligibility checklists. Where there's a lot of different things. If we go back to that roadmap, and if I had a magic wand, I would sort of like spackle, sort of think about the things that are the smoothing functions that help to smooth the rough edges of all of the building blocks for patient experience that we have. Because those are the things I think that really make healthcare hum, is when it's completely behind the scenes and frictionless to the patient, and that they are accessing care, having a great experience, but they're not even aware of the coordinating functions that are happening in the background to make sure that the right information is with the right people, and that the care has been organized in the most efficient way possible. So that's what I would do. I would, with my magic wand, I would spread spackle everywhere.
that's
smooth out
great,
the rough edges.
Yeah, that's a great point. I think you're right from the patient perspective. You know, if something seems super smooth, it makes you feel good, and I think you also just it'll make you feel like you're getting the best care. That it's speedy, it's good, it's well coordinated, and yeah, it's one of those almost intangible things. But yeah, wow, that's a great idea. Okay, well, Inga, thank you for sitting here and answering all these questions. I'm going to actually open it up to the floor and see if we have any questions from our audience. So if you have any questions, just please enter them into into the question panel, and we'll try to get to all the ones we can. Okay, so Inga, the first question I have is actually someone says, I'm actually an MGH patient and get all my care in the partner system. I find it infuriating to have to fill out paperwork, including name, address, health history, each time I see a new provider, as well as periodically at the same provider. Because partners should have all my info already. How can you improve this?
Oh, well, first of all, I appreciate the comment, and these are exactly the types of things that we are on the hunt to identify now. And this comes from, I know that this isn't really what the questioner was asking, but I think it's important to realize that this again speaks to how the practices grew up. Each and one of these ambulatory practices grew up as a separate siloed entity, and it's really recently, over the last decade or so, that they've been knit together, and that we even think of the ambulatory groups as like one thing. Before, it was always orthopedics or cardiology, or they're very, very distinct. So, but what they're asking about is something that we're trying to tackle currently. We're going through each and every front desk workflow for every place that is an MGH practice, and there are right now about 270 outpatient practices that at MGH in 55 different locations. So wow. The ambulatory enterprise is very big. So tackling the operations at all of these places is really important. But I will say there's a strong commitment on our part to streamline this experience, because we hear the same thing from many different people. And yes, it's what that one practice has gotten used to. And part of it is breaking that culture and saying we already know what that information. The patient just put it in the last time they were here. So we have to trust the system that we were using. And it has to be addressed not just at MGH, but across all of partners. And I think the questioner also mentioned that, is that it's infuriating when you go someplace at MGH, but then you go to another partner's hospital, and they may ask you the same thing again. And we are all on the same electronic health record. So it's a great question. It's something that we're actively addressing, and on multiple different levels, by front-end workflows, also by administrative organization, by incentives, and really at the top of leadership level across the electronic health record administration across all of partners.
Wow, yeah, and it's great to know that it's something that they know that needs to be addressed. And just imagine too, I think this is inside of MGH, which is all on Epic. Imagine another facility, another hospital, a referring physician who's not on Epic or not on your system, and that's even more of a hurdle to kind of get that information across.
Oh, definitely, most definitely.
Okay. Do you use Telemed yet?
We do have, I don't know if they're referring to a specific company or just telemedicine. So we do have a telemedicine group at MGH, and we do use what we call virtual visits. We have an internal platform that was built internally at MGH for our telehealth and telemedicine visits that actually happen in a secure fashion through the computer. So we do virtual visits, and they're available in many different departments now, and we're actively pushing their rollout in every department that it makes sense to use virtual visits in. We'll have a couple of different flavors of telemedicine. There's the virtual visits where, for instance, I have virtual visits available where patients are going through their CAT scans with me. I offer them a virtual visit so they can log on from home, and we see each other through a secure portal on the computer and discuss their CAT scan. There's also another flavor of virtual visits, which are consults, which we have a program where our doctors can be consulted from other doctors in different hospitals that we contract with that can access our specialists through a secure portal for a consult. So it's a doctor-to-doctor consult, and the patient may be in the office, in the remote doctor's office, and they call in to do a consult with our doctor. So I'm not sure if that's what the question is referring to, but we do have telemedicine and many different sort of flavors of that telemedicine experience.
Okay, great. All right, here's the next one. How do you think the technology you spoke about should be accepted by people who are in their 70s and above?
Oh, that's a great question. I love that. So we talk about this a lot, and actually, because we hear that sometimes, is that the slow adoption of some of this technology is due to the population of most people who are young are not yet ill, so they're not accessing healthcare. I think that's to some extent could be true, and there is some data to support that. But we also see some of the fastest growing user groups for things like Facebook are in the 70+ age range. So, and we do see more and more older people who are getting adroit at using iPads and smartphones. I do think, so I think age is less of a barrier for some of these technological advances. I do think socioeconomic status is definitely a barrier, as we see some of these technology, cameras that are embedded in computers or tablets and smartphones, that definitely SES related. Age is something that we worried about, but we've seen some of the fastest adoption in areas where we have older patients. So I'm not convinced that age is always the issue.
Yeah.
And there's different services that different groups really want to access. So younger patients want to be able to get answers to questions quickly, speak to a nurse, refills, things like that. Older patients might be more, we found that older patients are interested in accessing their specialists to do, consultations online and things like that. So I think what we'll see is some slivering of the market where we'll understand exactly what these different age groups are looking for from a telehealth perspective.
Right. Okay, great. Yeah, I think you're right. Access to the technology could be a big barrier, and that goes across all age groups. What about, we have another good question. What do you feel are the top 3 friction areas in the customer experience that should be attacked?
Oh, that's a great question. Well, I'll give you mine. So one of them is, and this is again from the MGH perspective, is understanding all of our channels for access. So like I said, you could go to our website, put in your name and ask for an appointment. You could call one of our clinics. You could have your primary care doctor refer you in. There's many different channels to come into. I think one of the challenges that we have is that we don't understand that total demand. There's not yet a way for us to quantify what the demand is for some of that access, and so it's hard for us to manage it. So one of the friction points, I think, is that in MGH is a very large organization, and we don't have a centralized access center yet. We do have a small access center, but it doesn't support the entire enterprise. And so we still have these pockets of different ways to access our appointments and groups, but that are difficult to centrally manage. So that's a friction point, I think, for patients, and that, when they call and they leave a voicemail and they never get a call back, that's something that I think is a huge point of friction. I think, so that's one thing, is how you access our appointments, whether it be by calls or emailing or referrals. That process can be difficult for us to manage internally. Secondly, I would say is communication about insurance eligibility and some of those things leading up to an appointment. So I'll give you an example. For a patient that's new, they have to register first before they can be seen, and there's, if you're accessing us by a phone call, we'll warmly hand you off to a different group that registers you, and then send you back to the scheduling side to get your appointment scheduled and your insurance eligibility done. And I think coordinating that conversation is something that we should do better. So, and I'll give you an example, is it's possible for a patient to go through the trouble of registering but never get told that there's an insurance eligibility issue until they've actually been scheduled for an appointment. And in the order of operation, that shouldn't happen from a customer experience standpoint. You shouldn't spend time registering if we know that your insurance isn't something that is going to be one that covers your appointment. So we're trying to do better to really think about the order of how those conversations need to happen to make them patient-centered. So the other thing is that insurance eligibility changes very frequently, so having an up-to-date grid of insurance eligibility is something that's a moving target, so can be difficult for us. So that's my second friction point. And then
okay.
I think the third, it's a long answer to your question, but the third is to improve the patient experience is a better EHR portal experience. And I know that our groups are working with, we have Epic, but we're working with Epic to really improve that, but only about 40% of our patients right now are signed up for our portal. And we're fairly new to this electronic health system, so I think we're right where we should be in terms of how long ago we've adopted it. But it would be much better if we had improved adoption and uptake of the portal experience so that we could really standardize the way that we communicate with patients. Because right now it's fairly fractured. Some patients are getting letters, others phone calls, reminders are going out via many different types of channels. So we're really looking forward to working with our vendor partners on improving the portal experience. And I know our leadership is really committed to that because we really want to get everybody sort of moving in that direction and communicating with us that way. So that was a long answer, but those are right now sort of three of my high friction areas.
Yeah, no, if you could solve those three, I think everyone would benefit. Okay, this is more on the side of back to technology. How does rising costs play a factor in technology decisions?
Oh, that's a good point. So,
I mean,
I
hospitals
think,
are just like anyone else, right? They look at revenue, they look at margins.
yeah. Well, especially in Massachusetts, we we have a very, well, I guess it all has to do with your perspective, but we are very conscious about the cost of healthcare, the cost of healthcare in an academic system, and really want to maintain the very highest quality that we can provide there. I think we're very realistic when we look out at the future and we see reimbursement as flat or decreasing, and some of the other challenges in the healthcare market are really going to leave us with challenges about how to best reinvest the margin that we do have. So I think technology is always one of those places, though, that we try and earmark, because we know that it's the thing that's really going to move the needle forward in terms of efficiency and improving the patient experience. So but it is increasingly at risk. I will say, as we look forward to the future, we are trying to use a very sober eye to look at sort of what healthcare in this region and reimbursement and costs are going to look like. And I think we've really realized that in order to have the funds to be able to reinvest in ourselves and in things like technology to make the world go forward, we really have to think very critically about our operations now to make sure that we're making the best decisions so that we can reinvest in that for the future. So I don't have a great answer for you. Costs play an incredible role, but I will say that there is, at least in my organization, there's definitely a little box around the areas of technology innovation. It's not that it's not going to be at risk. We will have to take a very close look at every expenditure, every cost that is in the system going forward. But I will say that there's a little bit of a protection around it in that we know that it's the thing that gets us closer to the future. And it is also what drives the change that makes us different and innovative. And so it's not completely protected, but there is some protection for it. So I guess
Right.
Unlike some other things, which I think we are more critically looking at, and if those things aren't fulfilling the mission of really driving us towards that future that we all hope for and can see, then we're taking more of a sober look at some of the other costs in the system.
And probably, I'm sure, return on investment is something that you guys look at as well, right? So the more that you can, justify the spend, the easier it is.
That's exactly right. That's exactly right. And that sort of goes back to one of the first comments I made about what is the problem that you're solving. There's some things that we see that, in a perfect world, I would love to have some technological advances in a variety of different areas. And some of it is really just interesting, but it doesn't necessarily solve a problem or have an ROI that's quantifiable. And those are the things that are the things that rise to the top, that actually solve a problem that needs to get solved and have a quantifiable ROI.
Great. Well, we need that magic wand, I think. Well, Inga, thank you so much. There are actually more questions, but we're running out of time. I just wanted to thank you for all the insights you provided in your time. I really appreciate this. I think our audience members also were able to kind of get some insight into how MGH operates and how they think about, moving forward especially with technology. So thank you very much for being our guest.
Thanks, Bill. It's been my pleasure.
All right. Take care.
All right.
Bye-bye.
Bye-bye.